start, Nishita?
Just give me a minute, ma'am. We are just going live. Just give me a minute, then we'll be introducing you and then we will be handing it over to you.
Sure.
So we are good to start, ma'am. With all your due permission, I'm beginning with the session.
Yeah, sure.
Good evening, everyone. This is Batul from IGCP, and I would like to welcome all the viewers who have joined our platform for the better exchange of knowledge that is going to be shared by our keynote speaker, Doctor, for today's session. She needs no introduction, but it's my pleasure and honor to introduce her at our platform. She's none other than Professor Dr. Madhulata Alexander, ma'am. Ma'am is MD in Obstetrics and Gynecology, Professor at the Government Medical College, Nizamabad, Telangana. With the help of ma'am, we'll be taking a close look on today's topic, which is abnormal uterine bleeding. Before moving on to today's session, let us have a brief look on what the topic says. Abnormal uterine bleeding is a common issue. Ovulatory dysfunction is the most common cause of AUB in women of reproductive age and occurs most often in women less than 45 years old, 50% of cases, and in adolescents, 20% of cases. We'll be knowing more about the topic with wonderful insights that will be shared by ma'am at our platform. So now, without any further delay, I would like to welcome ma'am and would like to hand over the session to her for her precious talk to begin. Ma'am, over to you.
Thank you so much, Batul. And it gives me great pleasure to be associated with you all and to discuss this common topic, AUB. I would like to give you some insights and some latest updates on this topic and how to manage all our patients who present to us so commonly in our OPDs with AUB. AUB, the problem is, if you really see, there are about 1/3 of OPD visits and more than 70% of consultations in the perimenopausal and postmenopausal years are because of AUB or abnormal uterine bleeding. In the US, it's almost as high as 53 per 1,000 consultations. And even the cost, as you see, it's causing billions of dollars, just a single disease. Now, in the postmenopausal women, if you see patients who have got CO endometrium, they present with vaginal bleeding in about 90% of these cases. So this shows us how serious this problem is and how it should be tackled. When you evaluate anyone with AUB, what are the aims? We have to establish the hemodynamic stability. And main thing, every time I'll keep on emphasizing, we have to exclude pregnancy. It comes actually number one in all our doubts. We have to identify the source of bleeding and evaluate whether the bleeding requires immediate medical and or surgical treatment. And of course, we have to detect serious underlying pathology like any cancer or any precancerous lesions. What is the definition of AUB? It is the flow outside of normal volume, duration, regularity, or frequency. Anything outside of this, which is normal, is called AUB. Now, FIGO in 2011-2012 started this Palm-Cohen's method of classification, and it is probably what is being used throughout the world now. And now we don't use the word DUB, dysfunctional uterine bleeding, which only said there was no structural abnormality in the patient. Now, PALM, as we all know, is the structural part, and Cohen is the functional part. And AUB HMB, that is heavy menstrual bleeding, has replaced the term menorrhagia. We do not use the term menorrhagia nowadays. And AUB intermenstrual bleeding has replaced the term metrorrhagia. There are other parts that the I is not yet classified, and I iatrogenic, and N is not yet classified. I'll be dealing with these later. What are the various abnormalities in frequency? Frequent, any cycle which bleeding that occurs during periods that start intervals less than 24 days. And if it's more than 38 days, it's called infrequent. So anything between 24 to 38 days is so-called normal. Absent periods, absent bleeding, that is absence of menses, either the primary where it never occurred at all, or secondary is when a patient had bleeding, regular cycles, and then for 6 months she did not have any periods. Now, if you see irregular bleeding, if you take the length of the cycle, the difference between the shortest to the longest, the cycle length varies between 7 to 9 days. Anything beyond this is called irregular bleeding. And prolonged menstrual bleeding is defined as any bleeding lasting more than 8 days. This is often, but not always associated with heavy menstrual bleeding. What is intermenstrual bleeding? It refers to AUB that occurs between well-defined cyclical menses. Now, cyclical mid-cycle intermenstrual bleeding, we are all familiar with. Basically, theory, it's supposed to be about 9% of all reproductive age females. Then after ovulation, when the estrogen level dips, there is a small amount of bleeding which occurs in mid-cycle. Acyclical intermenstrual bleeding is, it is not cyclical nor predictable. It is typically associated with non-malignant lesions, such as chronic cervicitis, endometritis, or polyps. Postcoital bleeding is a frequent symptom in any infection also. Less commonly, it can also be indicative of a pathological process, such as an endometrial or cervical cancer. The terms I said not used nowadays are menorrhagia, metrorrhagia, polymenorrhea, hypermenorrhea, oligo, and DUB, dysfunctional uterine bleeding. This is not being used nowadays. What are the abnormalities in volume? It can either be heavy or light. Remember, this is basically subjective, but heavy menstrual bleeding is defined as a volume that interferes with the patient's physical, social, emotional, and or material quality of life. Now, main thing is the who reports the patient, the heavy HMB, the patient herself. So it may not be very accurate. So they started doing something like direct measurement, and they started measuring it and collecting all the menstrual products and using the alkaline hematine method. And anything more than 80 ml was considered as heavy, but we all know how difficult, and it is not being used. Now, many indirect assessment of menstrual volume has come up, many charts. It's a semi-quantitative process, and it may sort of give you how much volume the patient is bleeding. Another entity we must know about is light menstrual bleeding. It is very uncommon and very rarely reported, although it may be a presenting symptom of cervical stenosis or intrauterine cyanic care. Now, these patients who report it, they may be concerned because they may perceive a heavy red bleeding as a sign of good health. So these patients only need some kind of reassurance. What about how do you classify severity of bleeding? It can be mild, moderate, or severe. In the mild kind of bleeding, the bleeding are longer than usual, more than 7 days, or they can be shorter, that is less than 24 days for at least 2 cycles, 2 months, with slightly or moderately increased menstrual flow, and the hemoglobin is usually normal, more than 10 usually. Moderate is slightly more prolonged, more than 7 days, or the menses may come within 3 weeks. The flow may be moderate to heavy, and hemoglobin usually is normal, that is with more than 10 grams. Severe is this bleeding is heavy, it causes a decrease in hemoglobin and may or may not cause hemodynamic instability. What are the goals? Maintain hemodynamic stability in the patients and evaluate. You have to evaluate the volume of blood loss at least by a baseline hemoglobin or hematocrit. Exclude pregnancy and try to identify the source of bleeding. You have to correct acute or chronic anemia and try to return the patient to a pattern of either normal or no menstrual cycles. And you have to prevent long-term consequences of anovulation, example, anemia, infertility, or endometrial carcinoma. Now, in each age group, the causes of AUB are different, as we all know. Pre-pubertal, before she attains menarche, trauma is a common cause of bleeding, maybe a foreign body or irritation of genital area, because these young girls are very fond of using douches, urinary tract problems, and of course, sexual abuse. All these causes also will be there in the causes of AUB in adolescents, but the most common cause being anovulation. This needs further evaluation. Pregnancy, infection and bleeding, there can be other medical illnesses also. Now, sometimes patients during adolescence, when they present with heavy menstrual bleeding, up to 20% of them may be having von Willebrand disease. So this should be looked into, or also any platelet dysfunction. Another point should be noted is any patient with history of severe acute respiratory syndrome, that is SARS-CoV-2 infection, anyone who had the infection or who had the vaccination, many have reported transient changes in their menstrual cycle. And I think we all have seen this in our practice. What are the various causes of the reproductive age? Uterine fibroids, adenomyosis or endometrial polyps colony, pregnancy, hormone birth control pills. Now these pills have a component of estrogen and progesterone. Sometimes if there is a breakthrough bleeding when taking these pills, we can increase the dose of estrogen or whatever, the patient doesn't have bleeding. Patients sometimes forget to take the pills, then also they may cause irregular bleeding. Now, injectable hormones, we all know, we have seen it commonly. Quite a few patients, at least initially, have heavy menstrual bleeding, and we have to control it sometimes by using extra hormones. Cancer or precancer of the cervix or endometrium, and infection or inflammation of the cervix also can cause AUB. Common infections include chlamydia and trichomonias. These patients also sometimes present with postcoital bleeding. Also, sometimes patients will be on anticoagulant medications. They may have platelet abnormalities also. Also, do not forget about medical illnesses such as hypothyroidism, liver disease, or chronic renal disease. Now, menopause and menopause transition also is an important cause of AUB. And menopause transition is the period just before menopause where women experience abnormal uterine bleeding. Ovaries here, they continue to secrete estrogen, though may not be at the expected level, and progesterone level declines because the cycles are becoming anovulatory. Now, these patients, many of them will think it's normal, but they should be counseled that further evaluation is needed in women with persistent irregular menstrual cycles or an episode of profuse bleeding. Of course, menopause, the high priority would be ruling out any pre-malignant or malignant cancer, and endometrial hyperplasia and carcinoma increases and presents in this age group. Infections and also use of blood thinners or coagulants should be looked into also. Now, looking at AUB, is it acute or chronic? There's no really standard definition of acute uterine bleeding. And acute uterine bleeding usually refers to an episode of heavy bleeding that is of sufficient quantity to require immediate intervention to prevent further blood loss. It may be an isolated event, or it can occur in a background of chronic AUB. This should be assessed, the amount of bleeding should be assessed, and how you evaluate acute and chronic is the same. After you assess the hemodynamic status and you assure the stability of the patient. Now, when you come to diagnosis, all this you have patient is presented to you, you have to come to the diagnosis. You have to go into the medical history. It's very, very important. Go into a detailed history, ask her exactly each and every medication that she is taking. Physical examination should include thyroid, breast, and family history also should be included, because it should not, patients who have had a family history of certain malignancies, we should also investigate for these malignancies in younger age group. Now, all of you know, people are very fond of taking herbal supplements, all these ginseng, ginkgo, everything. Many people love, everyone you talk to nowadays, I'm on herbs, I'm on organic stuff. Be careful, because some of these herbal supplements, they prevent platelet aggregation. So we must be careful. History of contraceptives, what they are using, NSAIDs or warfarin, you should go into the proper history. Now, this table gives you all the tests, what you should be doing, the basics, the very, very basic tests. As I said, the number one test will be pregnancy test. What I'd like to emphasize is, before administration of blood products or before starting hormones, please estimate the von Willebrand's factor. because after starting blood or starting estrogens, this factor may go into normal range and you may miss this diagnosis in the younger age group. Now, transvaginal ultrasound has been invented in the late 1980s, and it's something like a sonography, which is with a microscope, looking at a sonogram with a microscope. It is the best initial imaging test of the uterus, especially in postmenopausal ladies. If you use it in premenopausal or young women, it must be done in the follicular phase just after the bleeding ceases, so that when the endometrium is thin and you can see it without any hormonal influences. In a postmenopausal lady, if the thickness of the endometrium is less than 4 millimeters, you almost can rule out malignancy. Sometimes TBS, even in young women, you have to supplement with trans-abdominal scans, because sometimes TBS does not allow adequate assessment of the uterus or adnexa, or sometimes if there's a large pelvic mass, you have to go in for a TAS, trans-abdominal scan. I told you postmenopausal women, this is the first line of treatment. And in these patients, if you have failure to adequately identify a thin, distinct endometrial echo in a patient with bleeding, you should prompt further evaluation by performing a saline infusion sonography, office hysteroscopy, or endometrial sampling. Now, this is a picture of a saline infusion sonogram. This is a very beautiful picture because it's a very simple way. You just have to put saline into the uterus and take these pictures to the TBS. It's got a high sensitivity and a high negative predictive value. And usually, as I said, it's done in the follicular phase, and it can be done, this saline infusion can be done without anesthesia. It can be done in the OPD. It is less painful. Hysteroscopy is more expensive, it needs anesthesia, but nowadays the newer disposable hysteroscopes are showing promising results and encouraging. MRI CT. All our patients, if they have any problem, they straight away want to go to higher tests, as you can see in our practice. We must assure them that MRI and CT have very limited use. CT, of course, is zero. MRI, sometimes we need as follow-up imaging, very, very, very rarely. CT has zero value in AUD. Just a tail note about the rare causes of AUD, that is congenital adrenal hyperplasia. If a patient has also, along with hirsutism, if there is virilization present, you should think of androgen excess, and you should look for an androgen secreting tumor, either of the adrenal gland or ovary. Also, estrogen excess due to estrogen secreting tumors like germ cell tumors is rare, but it should be kept in mind. Now, isthmocele, it's now we're commonly diagnosing it because of this saline infusion sonography, and with the good ultrasounds, that is, this is also called a niche. This appears in the cesarean scar. It is also a cause of uterine bleeding, it causing AUD 65%. And the best method of repairing this isthmocele is by doing both a hysteroscopy and a laparoscopic approach, and this has to be corrected surgically. Now, when a patient presents to our OPD and she is stable, we do not immediately have to treat her. Okay, we first evaluate and then give the proper treatment. But sometimes, remember, in young healthy adults with normal vital signs, including postural changes, it may be normal because they have excellent compensatory mechanisms. Keep this in mind. Don't always think a patient who looks okay is actually okay. And for many patients with AUD, estrogen progesterone contraceptives are the first line management. In all books, in all up-to-dates, they have said the combined pills is the excellent and the first line management in the management of AUD. The advantages they say are, they make the bleeding more regular, lighter, they reduce dysmenorrhea and provide contraception. And people are more, if you tell them take hormones, they're very reluctant. But people are very happy to take combined pills because at some time, at some point in life, people are using combined pills and they are more familiar with to take combined pills. Now, what you have to do is you have to take combined pills with a minimum of 30 microgram ethinyl estradiol. First, start it with one pill 8 every hour until the bleeding stops. Usually it takes about 24 to 48 hours. Then you taper the dose. Now, these pills can cause nausea, so you may have to give a combined, you may have to give an antiemetic. And supposing you're tapering the dose of this COCs, if there is bleeding recurring, then you can temporarily increase the total daily dose to that lowest dose which controls the bleeding. Now, there are other estrogen progesterone combinations like the vaginal ring or the patch, but they are not used for treatment of AUB since it's not possible to vary the dose as precisely as with oral pills. And also, as I said, many people prefer OCs due to familiarity or other reasons. Now, another way of controlling AUB presence to you is you can use high dose estrogens. But if there are absolute contraindications, you cannot use it. The older generation is very fond of using this because they say the bleeding was controlled very easily, but nowadays, with advent of COCs, very rarely we are using these high-dose estrogens. They are contraindicated in some conditions, as we all know. They are given, the conjugated equine estrogen, 25 mg IV is given every 4 to 6 hours for up to 24 hours, according to the ACOG. Maximum doses given are 6. And usually they say bleeding subsides in 4 to 6 hours. And if the bleeding does not subside, you have to review your diagnosis and do other forms of treatment. Okay? And how it works is it bleeds, it subsides because it promotes rapid regrowth of the denuded endometrium and it stabilizes the lysosomal membranes and stimulates proliferation of the endometrial ground substance. When the bleeding subsides, you have to discontinue the IV estrogen and give an oral maintenance regime with, usually we give progesterones. Now, regarding this oral estrogens, there is no data available regarding the continuation of oral estrogens. But what we always give is progesterone should be given orally for about 10 days. And estrogen alone is more effective, but sometimes when you give combined pills, it may not act because the progesterones inhibit the synthesis of estrogen receptors and they increase estradiol dehydrogenase. So sometimes they do not act. Sometimes in some patients, like patients who smoke, who are a little obese, who have got hypertension, but not smoking continuously, or who have SLE, you can use estrogens for short periods of time, that is less than 4 weeks. And you should consult the primary care physician. And these patients should be informed of the potential risks of estrogen, like any swelling in the legs or unilateral leg swelling, any breathlessness on exertion or sudden breathlessness cough. They should be warned regarding these signs of potential thrombotic events. Now, the other group of drugs that we commonly use to control AUB is progesterones. They are usually used in hemodynamically stable patients and in whom the suspected etiology is from anovulation. They are used in whom estrogen is contraindicated, or sometimes patients have a taboo, they don't want to take oral pills. In these pills, we use high-dose progesterones to control their bleeding as first line. And we use a synthetic form of progesterone called progestins, like medroxy-MPA, medroxyprogesterone acetate, or the norethindrone. And this has got excellent control. You can give up to 5 to 10 milligrams per day. It can be given up to 4 times. But remember, large studies have not yet identified progesterone the risk of stroke or myocardial infarction. But history of venous thromboembolism is a contraindication to use progesterones because these progesterones are partially metabolized to ethinyl estradiol, which may elevate the risk of VTE. So oral progesterones are contraindicated in patients who have an elevated risk of VTE. Now, how do these progesterones work? They inhibit further endometrial growth. They stabilize the endometrium and they support it so that on withdrawal of the hormones, there is effective sloughing. These are continued at least for 5 to 10 days. But sometimes, remember, when they don't work is, sometimes the bleeding is so severe, the whole endometrium has been denuded, then these progestins are unlikely to be effective. Now, what comes into play is subsequent management is our wonderful Mirena. The LNG IUS 52 is often used for such patients, but we may have to use medical consultation before using Mirena, because this Mirena results in a very low systemic progestin absorption, and it has not been used, not been associated with venous thromboembolism. So, in an average risk patients with elevated risk of thrombosis, you can use this LNG IUS. People using it have fewer subsequent additional intervention, decreased oral tranexamic acid, decreased oral progesterone, and decreased hysterectomy. In fact, in the UK, hysterectomy has been decreased by 80% after the advent of this LNG IUS. But a bit about the expulsion rate. Expulsion rates are higher in patients using LNG 52 for treatment of heavy menstrual bleeding compared with those using it for contraception. That is up to 20% have expulsion rate compared to those using it only for contraception. That's only 10% have an expulsion rate. Now, tranexamic acid use of this comes lower down the list, but sometimes patients without use, if it is not responding, or they do not want hormonal options, as you know, then these patients can use tranexamic acid. It's an anti-fibrinolytic therapy, reversibly binding to lysine binding sites on plasminogen molecules. It can be used in bleeding disorders such as von Willebrand disease. Side effects include nausea, dizziness, and diarrhea, but it is contraindicated in thromboembolic disease, DIC, macroscopic hematuria, and color blindness. It should not be used in women, in girls who are less than 18 years of age, because there are not enough studies about it. NSAIDs are also used to treat heavy menstrual bleeding. Commonly used are ibuprofen, naproxen, and mefenamic acid. How do they work? By decreasing the PGE2 and PGF2 alpha, leading to vasoconstriction and decreased bleeding. They do not increase risk of thrombosis, so they seem to be safe, and there is no known contraindication to concurrent use. So you can use tranexamic acid and NSAIDs at the same time. They are prescribed from day 1, and usually about 2 to 3 days they can be used. Now, when do you hospitalize a patient? When there is one hemodynamic instability, yes, immediately you have to hospitalize her. Or when there's a need for blood transfusion, and each is decided on a case-by-case basis. When the hemoglobin concentration is less than 7 or even less than 10 with heavy bleeding. When you have to give intravenous therapy or any need for surgical intervention, you have to hospitalize the patient. Now, some patients, in spite of all this, the bleeding is not stopping. Then what you do is you go in for a dilatation and curettage. It can be used as a therapeutic intervention, but it should be reserved as a last resort for the rare patient who continues to have life-threatening bleeding despite other therapies. But remember, in adolescence, sometimes even we have used it. Therapeutic DNC has been done, but as I told you, it's the last resort. And when doing it, be careful, because you should prevent scarring of the endometrial lining and Asherman syndrome. So don't be too vigorous about doing the DNC. Endometrial biopsy, this I told you, is mainly in the older age group. This should be a first-line therapy and diagnosing. It should also be done as a first line in younger patients who have risk for endometrial carcinoma. Another form of controlling bleeding is intrauterine tamponade. Now, sometimes when a patient is bleeding heavily and we are stabilizing the patient, sometimes this tamponade has proved to be beneficial and life-saving, and we who work in the peripheries have realized the value of this intrauterine tamponade. Till you're waiting for more definitive therapy to come, you're waiting for blood products, or sometimes after curettage, when you know the patient is bleeding heavily, this intrauterine tamponade has been beneficial in many a time. We use the famous Buckley balloon, or you can even pack with gauze which have hemostatic solutions on it. And the kind of packing that should be used should be firm but not excessive, and pressure should be used to avoid uterine perforation. The main thing, it should not be kept in place for more than 24 hours. This is very, very important. And patient should be covered with antibiotics. Remember one thing, if packing does not control with hemorrhage, repacking is unlikely to be effective. This is very, very important. I have also seen in bigger institutes, when sometimes they remove the pack, there is pouring, then people are repacking. No, there is no use of repacking. Think of alternative measures to control the bleeding. Sometimes patients on anticoagulant, they say as much as 2/3 of patients on anticoagulant treatment are experiencing AUB. But this therapy is not the primary etiology of AUB. It exacerbates the underlying issue, and it is dose dependent. For example, if the patient is using warfarin, if the INR ratio is more than 3, adjust the dose so that the ANR becomes 2 to 3, and this often resolves the AUB. And patients for anticoagulant therapy, the great LNG IUS can be used. It can be used for AUB as well as for contraception. The last method of treatment will be surgical, and this is for hemodynamically stable patients. Sometimes it can be used as a first line. Like some patients do not want to go through the whole rigmarole of all the other treatments. They opt for surgical, but it's a very few nowadays. Sometimes medical therapy is contraindicated or it's unsuccessful. Then we go ahead for surgical management like endometrial ablation, uterine artery embolization, or hysterectomy. Now, what is this endometrial ablation? It is fast gaining popularity because it's a very simple procedure. It is very minimally invasive. It can be done as an outpatient procedure. There are no incisions. It is quicker post-operative recovery and very decreased cost. What do is they use heat, cold, electrical energy, or lasers, and they destroy the lining of the uterus. And people who are using this claim excellent results. Only thing is, patient should not desire future fertility. Patient wants for the children. You cannot use this method to control bleeding. But in spite of this, contraception will be necessary following the procedure. And before doing it, preferably you should do hysteroscopy to identify any intracavitary lesions. Contraindications include pregnancy, active pelvic infection, presence of an IUD, you have to remove that, or of course, any suspected endometrial hyperplasia or cancer. Uterine artery embolization is also, it is the first line of treatment for any AV malformation. Actually, nowadays, because of the scanning, we are able to diagnose AV malformations very quickly. So we are referring to higher centers who are able to do this, and people are getting very good results. It is used as the first line therapy. But the drawback being, if the patient is unstable, we cannot do this because it has to be done in a higher center and it needs some time to arrange everything. It can also be used as an effective alternative to hysterectomy. But the safety of pregnancy after this is uncertain. Okay, patients have to be counseled about this before doing it. And another entity called enhanced myometrial vascularity, EMV. It is being increasingly reported by the sonologists. It is distinct from AVM, AV malformations. And this involves RPOC, retained products. Patients are coming with these kind of diagnoses. Even these patients may benefit from uterine artery embolization. The last step is hysterectomy. It is reserved for patients who strongly desire differential surgical management. Many times patients, for whatever reason, they undergo some kind of half-heart treatment, they'll be counseled by somebody and they come requesting for hysterectomy. Of course, patients' wish should be respected, but it's our duty as specialists, as gynecologists, to counsel the patient what is correct for them, and they should be willing to choose, they will choose their own treatment. The main thing is it's curative. Medical management has failed. There is no need of repeating any procedures or no need of following up the patients. But it comes with a whole bag full of perioperative complications and prolonged recovery. So in summary, I would like to say, if there is AUB, the first line treatment in most cases is hormonal. That is combined oral pills. It can be treated either in the outpatient or inpatient. The second line will be progesterone only or intravenous estrogens. Hemostatic agents can be used, but only for about 24 to 48 hours it takes for the bleeding to stop. And of course, surgery is the last resort. Thank you.
Thank you so much, ma'am, for such wonderful insights upon the topic that you have shared. We hope that all the viewers who were here with us would have definitely got the knowledge that they were here for, and it's definitely going to help them in their daily clinical practices. So thank you so much for that. And we have received few questions, ma'am, from the viewers, so we would like to put it across to you.
Yeah.
The first question is, how frequently do women with abnormal uterine bleeding develop endometrial cancer?
See, abnormal uterine bleeding, I told you, comes in different age groups. Okay. So now usually endometrial cancer, the peak incidence is about in the perimenopausal age group. Now, if you take perimenopausal age groups, it is the number one cancer in that age group is endometrial cancer. Okay. And about 90% of patients with endometrial cancer present with bleeding. Okay. There's another side of this, that is, but the most frequent cause of bleeding in the older age group is senile vaginitis or senile endometritis. So any patient in that age group, you have to evaluate, you have to rule out any pre-malignant or malignant condition.
Thank you so much, ma'am, for answering this question. We'll move to the next question. And the question is, when is endometrial carcinoma included in the differential diagnosis of AUB and how is it ruled out?
No, when is it? Is it? When is it included?
Yes.
See, first thing is, it's usually in older age group, the priority is higher. Or if the patient is younger with risk factors, like she has chronic anovulation, PCOS, she has a family history, Lynch syndrome, those patients will have a higher suspicion. But as I said, you cannot leave a patient thinking it is malignancy. So older age groups, the incidence is higher. In younger age groups, when a patient comes to AUB, you are justified in treating her. But if she's not responding, think of other causes and rule out.
Thank you so much, ma'am, for answering this question. We'll move to the next question. And the question is, when should an underlying bleeding disorder be considered as the cause of abnormal uterine bleeding?
See, I suppose this patient is asking if you have an underlying, if you have a hemoglobinopathy. Now, if you really see hemoglobinopathies, about 20% of people in adolescent age group who present with AUB, they have hemoglobinopathy. So if a patient who's adolescent presenting with AUB, you are justified in doing a hemoglobin electrophoresis or other studies to rule out any hemoglobinopathy. In an older age group, just can't say, supposing in an older age group also, 1% of them present with 1 milligrams pathology. So in any age group, it can present, but most of the time they're present when the patient attains menarche. Now, when a patient has a major problem, that would have been ruled out when the patient was younger. Okay, where the patient would not have grown into adolescence or adulthood if that was not diagnosed. I hope this answers the question.
Thank you so much, ma'am, for answering this. We'll move to the next question that we have received. And the question is, when should an underlying bleeding disorder be considered as the cause of abnormal uterine bleeding?
Yeah, I think I just answered that, no?
This is the same question that has been asked by another viewer. So ma'am has answered this. We will be moving to the next question. So if you have any other question, we can take it, or else we can conclude it here.
Okay.
We'll just wait for a few more seconds, ma'am. If we have any other questions from the viewers, then we will take it. All right, so we don't have any other question, ma'am. Thank you so much for answering all the questions that were there from the viewers. And at the outset, I would also like to thank all the viewers for their ardent participation that they have shown. Indeed, every time, ma'am, whenever you are here at our platform, it's a great pleasure to share the same platform with you. So thank you so much. With all your last comments, we can conclude the session here for today.
Thank you so much. It's my pleasure.
Thank you, ma'am. Thank you.